My name is Louise Giles. I am a pediatric pulmonologist at the University of Chicago, and I am also a co-director for the Southside Pediatric Asthma Center. I am going to share my slides with you, and we'll get started on session 2 of our 7th annual summit, which is fantastic. So hopefully you guys can see my slides. If not, please share or just send a message and we'll start going through this. And I'm going to try to hide this other thingy. I don't know where to put it. Anyways, we'll get going. So today I'm going to talk about some updates in asthma management. And I'm going to first give you my disclosure. I have no financial disclosures to disclose, but I might be discussing some off-label use or investigational use in my presentation, and I'll let you know when it's off-label so that you can make up your own minds about things. But today what we want to talk about is something called GINA, or the Global Initiative for Asthma, because those are the guide for asthma that we follow at the South Side, and it's what we can see also at the university and what we do follow at the University of Chicago. Knowing how to apply the guidelines into your practice, what do the guidelines mean for community health workers, the community, teachers, etc., and talk about something called SMART dosing, or the new 2022 guidelines, and how that applies to patients. But I always like to start off with what is asthma, because we all need to be on the same page for asthma. And remember that over time, as we have gotten smarter and know more, we now know that asthma is a heterogeneous disease. So that means that there's many different types of asthma and many different ways that asthma can present. And that means different ways of how we might manage asthma. But the main underlying issue with asthma is that it's chronic airways inflammation. And when we talk about inflammation, because this is a mixed audience, I'll try to make sure that we're all on the same page. There's a lot of things that can cause inflammation, but when we talk about inflammation inside of the airways, I tell families it's just like your kid's eczema, or it's like if you scrape your knee. And oftentimes when I'm talking and teaching children, I'll use the scraped knee analogy, because almost every child has had a scraped knee. And it's swollen, it's red, it oozes, it hurts, all those things. And I say those are all the classic signs of inflammation. And that's what it can look like inside of your breathing tubes if I were to have a look with a camera. And that's what the real problem is. The real problem isn't the airway squeezing closed, it's that there's the inflammation there. The other thing with asthma is that you have to have a history of respiratory symptoms, and the history can include wheezing, shortness of breath or dyspnea, chest tightness, and cough. It can be all four, it could be one of the four or a combination thereof, but there needs to be a history there. It's really, really, really almost impossible to diagnose asthma with the first go around with cough and wheeze. And remember, right now we're having this amazing, horrific RSV infections that are just filling up our children's hospitals. And the problem with, but a lot of them, it's their very first time of wheezing, or it's their very first time with coughing. They don't have asthma, they've got bronchiolitis. It's a viral illness. So we have to have the recurrency to sit there and say, this is asthma. It varies in time and intensity. So as anybody who has asthma knows, there's times you're feeling better, there's times you're feeling worse, but it's all related to something that we call variable expiratory airflow limitation. And what happens is when we breathe in, our breathing tubes get bigger, but when we breathe out, they collapse down. And that's why it's expiratory when you're breathing out, that the breathing tubes get smaller, it makes it hard to breathe. And one myth that I would love to dispel is that asthma can be diagnosed in children less than 5 years of age. A lot of times people will sit there and say, oh, your kid's got bronchitis or bronchiolitis or something to that extreme. And no, bronchitis is almost never a real diagnosis in children, and we can diagnose asthma even in infancy as we move along. So there are different types of asthma. The most recognizable, the one that people most know about, and the one that is the biggest driver of our treatments to date is something called allergic asthma. It starts usually in childhood. There's usually a family history of allergic disease. They may also have atopy, so atopic dermatitis or eczema, allergies, seasonal food allergies, etc. And if we were to get a sputum sample from these kiddos, there's something called eosinophils in there. And eosinophils are a type of white blood cell that's associated both with allergic disease and parasitic disease. But often we can get eosinophils from inside their lungs. And these ones are the ones that really respond to the inhaled steroids. That's what ICS stands for, is inhaled corticosteroid. And those are the puffers that we consider to be the controller medications or the mainstay of asthma management. But there's also a non-allergic asthma that's not associated with allergies. When we look at their sputum, they have different types of white blood cells in there, or they might have none at all. And this is a bit harder to treat because they don't respond as well to the inhaled corticosteroids and might need other medication to try to control their asthma. There's late onset asthma. Usually in females who are about 40 years old or around that decade, non-allergic. The hard part is that they almost never respond to inhaled corticosteroids and need other forms of management. I don't have the star there because as a pediatrician, I don't treat the late onset asthma, but it's certainly there and it's certainly devastating for those who've got that. Now we do see asthma with what we call fixed airflow obstruction. And the problem with fixed airflow obstruction, it's usually due to asthma that has not been managed appropriately or as you're younger. And so what happens over time is that those breathing tubes or the airways develop chronic changes. And we call that airway remodeling, and they won't open up anymore. So that means if you can give them something like albuterol, but they usually won't respond and open up, and their lung function won't become normal even with albuterol. There's one that's becoming there's an asthma with obesity, and this is a tough one because there's two problems with this. We know asthma is an inflammatory disease, but so is obesity. It's a different type of inflammation, and they have a lot of airway symptoms. The problem with the airway symptoms is sometimes it's related to their obesity, and sometimes it's related to their asthma, and it's really difficult to tease out what is due to obesity and what is due to asthma. When you look at their sputum samples, there's almost no eosinophils in there, which means that basically it's hard to treat with inhaled corticosteroids because they don't respond to that kind of treatment as well. Then I put an arrow with something called asthma COPD overlap. And this is an adult disease where you have COPD plus asthma, and they're co-intertwined in that. But the reason I put the arrow there is that in pediatrics, we have another form of that, and that's called chronic lung disease of prematurity, or something known as BPD, or bronchopulmonary dysplasia. And these are kiddos who are born very early, premature, low birth weight. And by the time they hit term, meaning that, they're 3 months old, but this is when they should have been born, they still are having problems with their breathing. And a lot of these kids will develop asthma-like symptoms as they get older. And as with the asthma COPD overlap, these kiddos need usually more than just an inhaled corticosteroid to help out with their breathing as they move along. So the asthma diagnosis, there's many variations. Different phenotypes is the word that we use. And the key features are those breathing problems that vary in time and intensity, and the 4 cardinal symptoms, which is cough, wheeze, shortness of breath, or chest tightness. The criteria for diagnosis, you can see that there's nothing here that describes a lab or a breathing test or anything like that. The criteria is the history and evidence of what we call variable expiratory airflow limitations. So what is the evidence? Well, you could do that with a breathing test. If you're old enough, like AKA 5 years of age or older, we can do something called a spirometry test, and then we can give you some albuterol and say, oh yeah, look at this improves. So maybe you've got some airflow limitation. But there's just even more simpler things. You've got a kid who's got some breathing, you give them something like albuterol and they get better. Well, that's a good example. Or if a parent tells you, oh yeah, Johnny was having a lot of problems with his cough, so we borrowed somebody's inhaler and he got better and was able to go back out to play. There's some evidence with that too. Or so there's a lot of different ways you can try to get that evidence without actually going to any kind of testing. So what is GINA? GINA is a global initiative for asthma, and this is a slide that I borrowed from them for what's new for GINA 2022. And GINA's been around for at least a couple of decades now. It was initially developed by the CDC and the World Health Organization to try to bring asthma evidence that could be used throughout the world. So whether you were in Timbuktu or Tuktoyaktuk or Chicago, Illinois, the guide for asthma management was the same, so that everybody could sit there and look at this and say, okay, this is what's needed, this is what's necessary, and this is how we're going to relate our management. So like Tuktoyaktuk, which is up in way northern Canada, it's a small settlement of about 600 people. And it's where the midnight sun is in June, and there's like no sun at all at the end of December. It's a small community, but they could look to this guide and say, hey, if somebody's got these things with asthma, maybe we should put this child on this drug or that drug, right? So that we've got we've got the management plan. And that's to try to dispel a lot of things like, oh, I'm going to do it this way because of that. It's meant to standardize so we can try to get away with, or we could try to prevent some of those social disparities that can really interfere with good medical care. And whatever applies there applies everywhere kind of thing. It's now split off from the World Health Organization and CDC, and it's its own entity. GINA has different committees. There's a scientific committee that includes pulmonologists, respirologists from around the world, leaders in the field who meet twice a year to discuss and look at research and advances in what we know about asthma and that kind of thing. And then once a year suggests a change in how we're managing asthma and looking at asthma and so on and so forth. There is an assembly, which I'm a member of the assembly, and people in the assembly represent different countries from around the world. And our job is to take some of those things and educate people about that and try to bring this so that people can try to understand what we should be doing for asthma management. Now, you might sit there and say, why is something like this necessary? And that's because things change so quickly. And since we know so much more about asthma than we used to know, and it's good to move forward. We have to sit there and understand that as we learn more, we're going to try to change our management. We can't rely on our management of the past, or else we would be sitting there and we would be doing things like drinking, hen's blood that they used to do a couple of centuries ago, or even in the early 1900s, people were smoking tobacco to treat their asthma. Now, you and I today would sit there and say, that's ridiculous. We would not do that. And I'm going, that's right. That's because we now know better about what asthma is and so on and so forth. I mean, asthma was not known as an inflammatory disease until the late 1970s, early 1980s. So we have to move on and learn and just apply what's going on. So what's new in asthma? So for children less than 5 years of age, this is the slide that's for asthma management. You'll see down in the bottom, it's the 2021. It hasn't really changed, so I didn't change my slide. But basically, what it shows is that the main thing is that circle in the middle where it says assess, adjust, review, assess, adjust, review. This is we don't just sort of go up and down a stair. We go in a circle. We always are assessing, we're always adjusting, and we're always reviewing those kinds of things. And you're going to see this on all the others, but they basically all say the same thing. Assess. Are we sure this is asthma? Are we sure it's not asthma? Are there other comorbidities that are happening here? You talked earlier today with Damika talking about somebody really having like a lot of scented candles and so on and so forth in their home. We have to find out about things like that. That's where community health workers really help out, is with those comorbidities and what's going on in the home. We had one kid whose parent was scrubbing the house with bleach constantly. Well, can you imagine the kid breathing that in? So just things like that. So we need to know the comorbidities, and then adjusting. How can we modify that? How can we take that parent so that they're smoking outdoors? How can we sit there and say, hey, bleach might not be a very good thing to do. Let's switch it to green cleaning. Hey, the community health worker will help you find those things in the home that might be bugging your child's asthma, and going on from that, and then making sure that they're on the right medications. I'm not going to spend a lot of time on the medication part of this because my talk is about what's brand new. But basically here for little kids under the age of 5, we would start them on an inhaled corticosteroid. So for you guys, that would be Flovent, Pulmicort, QVAR are the more common ones that are out there. And then if that doesn't work, we're going to go up on that. And if that doesn't work, we're going to send you off to be assessed by somebody like me. Okay. And at the bottom, it says, okay, who would we put this on? So a lot of times, if it's like a little 2-year-old who's had frequent respiratory illnesses, has ended up basically like little Eric that Damika saw, your kid's having all these frequent things, maybe send them and let's start them on something, make sure that it's under good control in that. And then we've got our add-ons to go from there. Now, have I put children under the age of 5 on significant medication? Oh, sure I have, but I'm also a subspecialist. My job is to take care of people with severe asthma or hard to treat asthma. So this is something that's unique to me, but again, as Damika said, a primary care physician would need to send these kids to somebody like me, because that's my job, and their job is to take care of the whole child. So 6 to 8 years of age and up, this is where things get very interesting, because before we would just sit there and say, oh, if they've got really mild asthma, so their asthma is not that frequent, we're just going to put them on albuterol and let them use albuterol. Here, if you look here, okay, for step 1 or very mild, it's a low dose, like a Flovent, taken whenever the albuterol is taken. That's a change. That's a shift in our mindset. And why is the shift in our mindset there? Well, the shift in the mindset is because of good research, and because we don't rely on what we were doing even 10 years ago, because things change. We know that if you need to take your albuterol, there has to be some level of inflammation in that airway. And relying just on albuterol is not recommended anymore. So if they need to take their albuterol, they take their Flovent. Now, that's sometimes difficult to do, because if they're at school and they need their albuterol, well, what do? I tell the parents to give it that evening. Or put them on a low dose, very, very low dose inhaled steroid, and move forward from that. So you're also going to see here, as a reliever, you could use what's called an ICS formoterol. That's Symbicort or Dulera. No other combination medications. Both Symbicort and Dulera have that inhaled steroid there. And formoterol is a medicine that's just very similar to albuterol. It acts just as fast as albuterol, but it lasts for a longer period of time. Okay, so this would be, and I'm going to get you're going to sit there and you're going to say, oh, that's Symbicort 100, Symbicort 200. Wait a minute, we have 80 and 160 and 4.5 milligrams of the formoterol. This is international dosing. The US puts their dosing as a different, they just do it differently. So everywhere else in the world, it would be 100, 200. Here it's 80, 160, exact same drug. But here we're talking about Oh, their reliever can be their controller medication. Interesting. Very, very interesting. But again, that's because we want the steroid in there along with a fast-acting reliever medication. And we're trying to get away from albuterol, which is a short-acting beta-2 agonist on its own. When you look at older kids, now look at this, as needed combined therapy. And then you go into low dose, medium dose, and then maybe adding on. And this is where I'm really, this is the stuff that I do, okay? But here you go, is the alternative, take their steroid whenever they take their albuterol, and then start moving up that way. So this is the preferred method, and this is the low dose and inhaled corticosteroids. So this is what we call SMART therapy, or MART therapy if you're to read the 2022 one. We used to call it variable dosing, but variable dosing only existed elsewhere, not in the United States. So we're trying to catch up here in the US with this. And this is where it's off-label. And the reason I'll say it's off-label because the FDA hasn't really fully approved this. They're ignoring what we're doing in the pulmonary world, but this is certainly something that all other major countries, so I'm going to include Canada, the UK, Australia, the European Union, etc., have been managing asthma for quite a period of time now. So when I talk to families about this, they say, well, you know, this is new for the US. How do I know it works? And I tell them that my daughter, 18 years ago, maybe a bit old, maybe 17 years now, was diagnosed with asthma as a teenager, but she really didn't need everything every day. And we knew about this variable dosing with Symbicort. So that's what she started on, was variable dosing Symbicort. That's what she's been on her ever since. That's how she's managed her asthma. She has never carried a true reliever medication like albuterol. She does it all with Symbicort, and she's been fine. So she keeps her asthma under good control that way. And that's, you know, that's my N of 1, but nevertheless, we were doing this when I was in Canada, and then I had to revert back. So it's not FDA acknowledged right now, but it's the preferred way of treating. So what happens is that when we go into their maintenance doses and they have their reliever dose, so let's say I have a child and I'll put them on a drug like Symbicort or Dulera, because those are the two medications that we can do this with. They take that as their morning and evening medication. Then if they have issues during the day, either with exercise or they're starting to get sick, they can use more of Symbicort. We really don't want them relying on albuterol anymore. And I tell them they can go up and down as needed, and keep their asthma under control. And the families that I have who are following that are thrilled to death with it, because they just feel that their child's asthma is so much better controlled. We do put top limits of the number of puffs. If they're under the age of 12, they can go up to 8 total puffs in a day. If they're older than 12, they can go up to 12 puffs in a day. I had a friend, this was back in Canada in Winnipeg, and she really hated prednisone, and she was one of those, she had asthma when she was little, got much better, and then it came back like a vengeance as an adult. And she kept her asthma under control doing 4 puffs of Symbicort 4 times a day, and that's how she stayed off of prednisone. But she was able to do her job and do activity and so on and so forth. So it's just a really great way of trying to keep things under control. And this is personalized medicine, and this is the way we're going to go with that. So practically, what does that mean? Well, it's, you know, initial treatment is never weight-based, right? It's just for inhaled drugs, the size of the breath really does help control what you're doing there. But initial asthma presentation, this is usually where I see people. I usually put them on this. So this is something that can be used by physicians. It's in the GINA guide, where you can look this up and say, okay, if they've got infrequent symptoms, what do I need? And so on and so forth. So that's really nice that way. And also we do the steps in the GINA guide, because we do know that that's what a lot of people like. But basically we've got the steps in there, and the same thing with starting treatment at different ages. So we no longer recommend albuterol only treatment because it increases the risk of severe exacerbations. And we know that all patients with asthma should receive a steroid-containing medication. And we've got lots of proofs and information about. So these are the two, Dulera and Symbicort, that you can do this with. A lot of the research has been done with Symbicort, but Dulera will work just as well. And we do know that this works overall. So we have to really think about appropriate medication for asthma management. The dogma of albuterol is so passé. Asthma action plans will look differently as a result. And it's important that these changes means better asthma control and reduced deaths. And this is why. Why no more albuterol alone? Well, albuterol has been around for a long period of time. It's been around for like 40 years now. But we know that what happens, it downregulates beta receptors. What are beta receptors? Beta receptors are little tiny receptors, or like a little tag on what's called airway smooth muscle. Those are the things that contract to make your breathing tube so tight that you can't get air through it, right? But if you're using albuterol all the time, those become less responsive. They don't want to interact with albuterol anymore. So what that means is that you have decreased bronchial protection. That means those airway smooth muscles won't open up. They won't relax. You also can get rebound hyperresponsiveness. So we had a kid that came in and was discharged from their asthma exacerbation, and the instructions were to continue 4 puffs of albuterol every 4 hours. What mom missed was reducing that every single day till they didn't need it anymore. So she kept up with that. And over about a 2-month period of time, her kid's asthma was getting worse and worse and worse. And it wasn't getting worse because the asthma was getting worse. It was getting worse because too much albuterol. You can increase allergic responsiveness if you have too much albuterol. We know that if you use more or equal to 2 canisters in a year, you've got a higher risk of having emergency room visits. And if you use, actually that should be 10 canisters in a year, you've got a 10-fold increase in the risk of dying. So we know this is bad. So how do we reduce the risk? We get them on steroids. And so this is, you know, that our logo is a butterfly. I decided to pick out a pretty purple and blue butterfly for my last slide. But what this means for community healthcare workers, for teachers, and everything else, that you're going to see changes on those asthma action plans. And if the asthma action plan states that they should be doing this in these stages, then teach them, sit there, say they're trying to get away from albuterol, because we know albuterol can be harmful if misused or abused. And if you're seeing a patient and they're using a lot of albuterol, encourage them to go into their doctor and saying, listen, I know that I've heard that this can be bad to use so much albuterol. How can we reduce how much albuterol my kid is taking? And so that we can go into safety first for our patients and getting them on the right medication.